Hello and welcome to this lecture. Today we are going to discuss hypertension. So I start my topic with one of the case presentations. A 50-year-old man with a history 15 years of hypertension, a history of smoking 2 packs of cigarettes a day, and diabetes mellitus experienced the own acute onset of weakness and numbness on the left side of his body and an inability to walk. He admits to having a severe headache. His wife reports that during the ride to the emergency center, he became lethargic. His blood pressure upon arrival was 192/105 mm of Hg. So the learning objectives in regarding to understand this case study that how can we define systemic hypertension, what are the risk factors of essential hypertension, what are the causes of hypertension, discuss the prevalence of hypertension, describe the pathogenesis of hypertension, and how could you compare the morphological characteristics of hyaline arteriosclerosis and hyperplastic arteriosclerosis. So how can we define systemic hypertension? It is defined a sustained elevation of systemic arterial blood pressure. So how can we determine the systemic hypertension? We can measure using sphygmomanometer. So what is a normal limit of systemic hypertension? It depends upon age. Uh, if we see in this picture, you can see that with the increase of age from 20 years to 50 years, you found that the systolic blood pressure and diastolic blood pressure both increases. The normal limit around age 20 is 140/90, and then it increased to 160 to 95 in age around 50, whereas it can increase further with 170 systolic blood pressure and 105 diastolic blood pressure. But in some of the textbook, they mention in that age 20 years is 120 systolic and 80 diastolic. So some textbook mention 140 systolic and 90, and some of the textbook they recommend 120 systolic and 80 diastolic. So it varies, but the range is around 120 to 140 systolic blood pressure and then 80 to 90 diastolic blood pressure. So we explained the diastolic blood pressure that usually below 85 is considered normal. Then 85 to 89 is high normal. 90 to 104 is mild hypertension, and then 105 to 140 moderate hypertension, and more than 115 is considered as severe hypertension. For systolic blood pressure, the normal range is below 140. As I already mentioned, 120 to 140 is the normal range. Some textbooks mention 140, whereas some textbooks mention 120. And they mention as well that when the diastolic is less than 90 mm of Hg. If the diastolic is high, then this range will be changed. So when the diastolic is less than 90, then this is the range 120 to 140. And if it increased from 140 to 159, then it is considered as borderline hypertension. And the further increase of the hypertension above 160 can be termed as isolated systolic hypertension. But remember, in that case, this 160 have systolic, then the diastolic is below 90. So it means that a person having an increase of only systolic hypertension, whereas diastolic blood pressure is normal. So sometimes this happens sometimes to the patient that only the systolic or the upper level is high and the lower level is normal, or sometimes the lower level is high and upper level is normal. So it's depend. We classify hypertension into two subcategories. One is essential hypertension and secondary hypertension. What are the risk factors for essential hypertension? Obesity is the one of the factor that can cause hypertension. Then if a person has increased the salt intake such as sodium, then it can cause hypertension. Then excess use of alcohol can cause liver cirrhosis and can leads to portal hypertension. Lack of exercise in another reason for hypertension. And then the last is the stress. So if the stress increases, then it is also responsible for hypertension. Some of these are all known as modifiable because obesity, increased salt take, alcohol use, lack of exercise or stress can be changeable. But there are some factors that are unmodifiable and that linked to the genetic factor are the race or heredity or age group, like mentioned, African American or Asian, or heredity because run in the family, or age group older, as we mentioned that above 50 age uh, can leads to the hypertension. And if we take a look of our case study, they mentioned that two reasons of hypertension. I found that if the age of the person is 50 years old man, so it means age is more than 50 years. Then they have the 15-year history of hypertension. So it means that it may have chance that the hypertension occur because of the family history. So these are the things that he is actually chronic hypertensive patient that we can see from this report. And then we see that his blood pressure is 192 systolic and 105 diastolic, which is quite high. And usually patient don't know that he is having a hypertension. This is very common practice that people they don't realize that they are having hypertension, and when they go to the hospital maybe for other clinical purposes they get diagnosed. Like in this case, usually a severe headache, if there is no etiology and there is no reason and a severe headache a person face, then sometime it will be maybe one of the reason for hypertension. So we discussed the definition, the normal limits, the classification, and the risk factors. Then, what are the causes of secondary hypertension? And the secondary hypertension could be caused because of the renal disease. As we know that there is our system, renin, angiotensin, aldosterone. And if the aldosterone, we know that is the hormone that will be released, and renin angioaldosterone system is responsible for the retention of sodium and water. So if there is some issues regarding the renal diseases, because some of the disease can affect the renin angiotensin aldosterone system, and if there is an increase of the aldosterone or increase of the renin, then it will result in increase of the sodium absorption and water absorption, or reuptake of water and sodium, and then it will result in the secondary hypertension. The other is endocrine disorder. As I already mentioned, the aldosterone is the hormone, and that released from the adrenal gland. So the disorder of the endocrine disorder can be possible. Renal disease, actually renal disease and endocrine both are linked, because renal diseases sometimes are linked to the renin angiotensin aldosterone, or renal disease could be because of the idiopathic increase of the absorption of sodium ions. Then the other reason could be the vascular causes. Vasoconstriction is the example like that. The vasoconstriction can lead to hypertension. Then we have drug-induced hypertension. Some of the drugs may cause secondary hypertension. For example, amphetamines are the example. So if somebody is taking amphetamine, and then it can cause hypertension. Then alcohol use, because excessive alcohol use can cause liver cirrhosis and can lead to portal hypertension. Pregnancy, in case of pregnancies, hypertension is also possible, and if a woman is suffering from hypertension, then it can cause some complications, and it is very important. Then neurological diseases such as Alzheimer or Parkinson disease can lead to the hypertension. The other reasons could be psychogenic reasons or increase of ICP. What is meant by ICP? ICP stands for intracranial pressure. So the increase of the intracranial pressure can also lead to the hypertension. Let's discuss the epidemiology of hypertension. The prevalence of pathological factors of high blood pressure increase with age, as I discussed before, and also higher in African Americans, as we discussed this before. Without appropriate treatment, some 50% of the hypertensive patients die because of the ischemia or ischemic heart disease or congestive heart failure, or can come to stroke. A small percentage of hypertensive patients, around 5%, with a rapid rising blood pressure that, if untreated, lead to death within 1 and 2 years. So the mortality rate, we can say that the death within 1 and 2 years, if possible, that the patient is not treated for hypertension. So what is ischemic heart disease? Is you can see the artery will be blocked because of the cholesterol level, high cholesterol level, and then it can lead to ischemia, and it can damage the heart muscles. Then we mentioned that heart failure is the reason if patient is not treated well. And what happened that heart muscles weaken, and because they are reason that the blood is not pumping properly, and less blood is pumping out, and it can lead to heart failure. Or heart is not relaxing normally, and the stiffness of the myocardium or the ventricles uh, will result in less blood fill in the ventricles. So they are all reasons for the heart failures. Then again, the stroke could be possible because if the due to, there are two reasons. One of the reason is blood clot in the cerebral arteries that can lead to stroke, or if the blood clot break and travel to other part of the body. What is the pathogenesis of hypertension? There are two reasons that has been explained. One is the reason of the genetic influence, as we discussed as we have discussed the African Americans that have more chances to become hypertensive, or the environmental factors such as the lifestyle, your diet intake, like such as sodium intake, obesity. They all can lead to the pathogenesis of hypertension. And what they affect in three ways. Number one is the defect on renal sodium homeostasis. It means that the increase of the absorption of sodium. And why this happen? It could be possible because of the hormonal disorders, like the increased production of angiotensin, aldosterone, especially the aldosterone production. Or it could be functional issues such as vasoconstriction that can lead to hypertension. The third one is the defect in the vascular smooth muscle growth and the structure. It means the effect in the myocardium of the heart, such as the muscle become either too stiff, or you can say that if you take a look on that heart muscle cannot squeeze the blood properly. Like if I mention here the increase of the vascular wall thickness, and if the vascular wall thickness become more and more, then blood cannot pump or blood cannot fill inside the heart properly. And I mentioned here the functional vasoconstriction causes the vascular reactivity, and the increase of the vascular reactivity leads to increase of the total peripheral resistance. And with the vascular wall thickness also result in the increase of the total peripheral resistance, and that leads to the hypertension. Whereas in the genetic defects, if it caused because of the more absorption of the sodium, then what happened, there will be an inadequate excretion of sodium. The sodium will not excrete it properly. More salt and water retention occur, and more salt and water result in increase of the plasma and extracellular fluid volume, and increase of the cardiac output that result in hypertension. So that's how these mechanisms work. Now discuss the morphology of hypertension, and we are discussing two type of hypertension. One is caused because of the hyaline arteriosclerosis, and the second one is hyperplastic arteriosclerosis. And the hyaline arteriosclerosis are associated with benign hypertension, whereas hyperplastic arteriosclerosis is more typical to severe hypertension. So when we take a look of hyaline arteriosclerosis, again the main, as the name indicate, is hyaline. So we are talking about the arteriolar wall is thickened with the deposition of proteinaceous material which is hyalinized. So the deposition of the hyalinized material is responsible for benign hypertension, and you can see that if you take a look of this sex structure or this side, you can see that the lumen space become narrowed, and that the space surrounding is occupied with the proteinaceous material. You can say a protein like material or a protein deposition, and that protein deposition is explained in terms of the presence of hyaline. And as a result of deposition of the protein material, the lumen become narrowed, and then it can increase the total peripheral resistance. This is another picture of hyaline arteriosclerosis. You can see this side section, the thickness, the narrowing of the arterioles because of the deposition of the hyaline, or you can say the protein material in simple word, and that result in that section and become too narrowed. You can take a look of this structure, and due to this narrowing of the new lumen, it can increase of the total peripheral resistance. And you can see these structures, these small narrowed lumens, and that showing you the causing the hyaline arteriosclerosis. This is the example of hyperplastic arteriosclerosis, which look like an onion skin. If you are familiar with the onion and you like to eat onions, you know that how onion look like. So they use onion as metaphor. And because of the appearance, it's look like onion. They mentioned that this is a key characteristic for hyperplastic arteriosclerosis, and this is a key differentiation between hyaline arteriosclerosis or hyperplastic arteriosclerosis, which causing luminal obliteration, and it can be diagnosed with the help of stain, which is known as periodic Skiff stain. This is a key characteristic in hyperplastic arteriosclerosis. And this is a picture of to compare hyaline arteriosclerosis, which this material is showing you the presence of the hyaline material. And in hyperplastic, you can see that these are the presence of like circular material, which is, we can say that fibrinoid necrosis. Initially start with proliferating muscle cells, whereas in case of hyperplastic arteriosclerosis, we found the proliferating smooth muscles, and we found some of the presence of neutrophils. And then later on, if the hyperplastic arteriosclerosis prolonged, then it can result in fibrinoid necrosis. And this structure showing you the fibrinoid material, the presence of neutrophils, and then it can result in necrotizing arteriolitis, which is the inflammation of the arterioles. So thank you so much for today's lecture. Hope to see you again.